everyone, today we're going to be talking about opioids, but specifically opioid analgesics.
So the big question is, what are opioids? Opioid is a general term defined as any drug, natural or synthetic, that has actions similar to those of morphine. Opioid receptors act primarily by activating mu receptors, which produces analgesia and sedation effect. Narcotics are used for an analgesic effect, a central nervous system depressant, and any drug capable of causing physical dependence.
Here is a picture of where opioid receptors are located throughout the body.
Now let's talk about the mechanism of action. Opioid agonists work by blocking the release of neurotransmitters in the brain, spinal cord, and other tissues, which help in diminishing the effects of painful stimuli. They open potassium channels, then they prevent the opening of calcium channels, and this in turn inhibits the release of other neurotransmitters.
But why would we use opioid analgesics? We could use it for acute trauma or injury, treatment of postoperative pain, chronic conditions for which cures are unknown, malignant processes such as cancer, and moderate to severe pain, including neuropathic or nociceptive pain.
The contraindications for use include if someone has a low tolerance to opioids, if the respirations are under 12 breaths per minute, or if the patient is suffering from any respiratory problems like asthma or emphysema. We would also not give opioids to a patient with a head injury, urinary problems, or issues with drug or alcohol abuse or dependence on opioids.
Now let's talk about pharmacokinetics, which includes absorption, distribution, metabolism, and excretion.
Opioids can be absorbed in many ways, by mouth, intravenously, intramuscularly, transdermal, and through intraspinal methods like an epidural. Also, let's not forget about rectally in the case of a real emergency.
Opioid distribution is important because only a small fraction of each dose reaches sites of analgesic action due to poor lipid solubility in the brain-blood barrier. Opioids such as morphine are rapidly distributed within the body and the CNS, but in smaller quantities. Opioids can cross the placental barrier and affect the fetus, so do not take these while pregnant.
Opioids are broken down in the liver, and most are inactivated through the first pass effect. Because of this, oral doses should be given in larger quantities than parenteral doses to achieve the same therapeutic effect.
While opioids are metabolized in the liver, the kidneys excrete opioids by the processes of glomerular filtration and tubular secretion through urine.
Normal dose ranges for opioids are highly individualized, and dosing follows the motto, start low and go slow. The dose of an opioid will increase based on the patient's tolerance. Generally, opioids should be given on a fixed schedule to spare the patient needless discomfort. However, opioids will be given PRN for breakthrough pain. We give an example of the normal dosage of morphine.
When making dose adjustments, you should consider the patient's pain tolerance, level of pain, the patient's age, and if there's any liver or kidney impairment, and if the patient is taking any other pain medication.
Patients being prescribed opioids should be informed to take their medication as prescribed. In addition, they should be made aware of possible adverse effects such as drowsiness, constipation, dizziness, and depressed respirations. Also, avoid using opioids with other CNS depressants like alcohol. Do not derive or operate machinery while taking opioids.
Further, patients should be educated not to stop taking their opioid medication without doctor's advice. In addition, patients should be informed that opioids can become addictive, and if needed, they should seek help. Finally, tell the patient that opioids need to be kept in a safe, locked place away from vulnerable populations.
Certain patients who are at risk for respiratory depression must be monitored closely when taking opioids. Narcan should be kept on hand for patients taking opioids as it can reverse respiratory depression. Caution should be taken in patients taking additional drugs that can also depress respiration. In addition, giving an opioid along with a non-opioid may increase analgesic effects.
The nurse should give the opioid drug at least 30 to 60 minutes prior to activities or painful procedures. Also, morphine should be used with caution during pregnancy, labor, and delivery. In addition, opioids must be used with caution in patients with head injury, as opioids can exacerbate symptoms of respiratory depression. Finally, effects may be intensified, prolonged in patients with liver impairment.
There are many drugs which interact with opioid agonists. Among these are CNS depressants, anticholinergic drugs, hypotensive drugs, monoamine oxidase inhibitors, agonist opioids, and opioid antagonists.
Regularly monitor the intake and output, the source, quality, and severity of a patient's pain, and the patient's vital signs and mental status. Further, monitor the patient for respiratory dysfunction, specifically looking for respiratory depression.
Assess the patient for dizziness, euphoria, and level of consciousness, any symptoms of allergic reactions, pain based on a pain scale, and for side effects such as constipation and symptoms of overdose. Always assess vitals prior to giving an opioid.
And here are our references. Thank you and goodbye.
Created using Powtoon.